This conference will now be recorded.
So, good morning. Am I audible to you?
Yes, ma'am. Audible, ma'am.
Yeah. Okay, very good. Today we are dealing with fat soluble vitamins. As you all know, fat soluble vitamins are A, D, E, and K. So, coming to the vitamin A, so vitamin A refers generically to the compounds that are structurally related to the retinols. There are 6 forms of retinols we have seen, like 7 cis retinol, 9 cis retinol, 11 cis retinol, and 13 cis retinol, and all trans retinol. The oxidation products of this retinol, such as all trans retinol and all trans retinoic acid, are the active forms of vitamin A. So some of the carotenoids in the vegetables or the fruits are the proforms of vitamin A. All trans beta carotene is the most effective precursor of the vitamin A. So how this absorption of the vitamin A occurs? So the retinol absorbed by the active transport system by the CRBP2, that is cellular retinol binding protein. So this LOB carotene also requires the bile salts for absorption, and it is converted in the intestine to the vitamin A. So all the coming to the absorption, whatever forms of retinol we ingest or the beta carotene, which are the precursors of vitamin A, all these are carried by the cellular retinol binding protein, which requires a bile salt for absorption in the and also converted to vitamin A in the intestine. Where this vitamin A is stored, it is stored in the liver as retinol palmate. So, and from the liver, it is circulated and released into the blood, which is bound to retinol binding protein and also a prealbumin called as transthyretin. So, what are the sources of vitamin A? So, all we have already know that carotenoids are the good sources of vitamin A. So, all the colored foods like carrot, dark green leafy vegetables, tomato, orange, and coming to the non-veg parts like shark or cod liver oils, these are the sources of vitamin A. So what is the RDA of vitamin A? In infant, the RDA is 300 to 400 microgram. But in children, the RDA starts from 400 to 600 micrograms, and adolescent it is 750 micrograms. These are the daily recommended doses. So what are all the physiological functions of vitamin A? We all know that vitamin A is required for the vision, and especially the night vision. It helps us in differentiating the epithelial tissues during the reproduction. That is, during the reproduction, various epithelial tissues are formed, and during the gestational age also various epithelial tissues are formed. This vitamin A plays an important role in differentiation of the epithelial tissues, and it helps in the night vision, and it helps in keratinization of the skin. So how the vision is controlled by the vitamin A? In the eye, there is a lens is retinal. It is found bound to the cones and rods of the eye. So when we come to the eye part, we have rods and cones. Rods and cones contain lens is retinal. In rods, it is called as rhodopsin, or in cones, idopsin. This lens is retinal. When the light enters the eye, this lens is retinal is isomerized. And all forms of isomerization occurs when light enters the eye to this lens is retinal. This the all trans form dissociates from opsin by bleaching. So the signals are transmitted to the visual center of the brain by nerves induced by the isomerization. What happens? This isomerization of the lens is retinal induces the nerves which carry the signal to the brain visual center. After completion, this all trans retinol is recycled and again converted to lens retinol. So after all this conversion, the all trans retinol is again recycled and is converted to the lens retinol. This lens retinol will rebind to the opsin to form rhodopsin, which is required to see black and white, and also for the night vision. Some all trans retinol binds to the interphotoreceptor binding protein, that is IRBP, which helps in pigmentation of the epithelial cells. So all these process occurs in the rods and cones, and the substance needed is the lens is retinol. So in the lens is retinol in the rods and cones. In rods it is rhodopsin, and cones it is idopsin. This undergoes the isomerization process. This repeated isomerization will trigger the nervous system, and through the nervous system they enter the visual cortex of the brain. The signals enter the visual cortex of the brain, and which also interrelates which also in this process dissociates the all trans retinol from the opsin. So again, after completion of all this process, the all trans retinol, which is dissociated from the opsin, again gets recycled and converts to lens retinol and again stored in the rods and cones. This helps in the differentiation of the black and white, and also in the night vision. And some of the forms are sent to the epithelial cells for pigmentation. So already we have discussed the absorption which occurs in the intestine by cellular retinol binding protein, and which requires bile salts, and it is released into circulation by bound to retinol binding protein and prealbumin. We know the RDA, we know the sources, and we know how it is getting functioning. And it helps. So main functions are the night vision and epithelialization and differentiation during the reproduction process and the gestation age increase. So what happens in other vitamin A deficiencies? The vitamin A deficiency also, if it is present, it leads to repeated infections. Like infections are the most common causes of death in our country, and harmful infections like measles are occurring during the vitamin A deficiency. It leads to night blindness, and there is a defective dark adaptation time when there is vitamin A deficiency. So what are the clinical features of vitamin A deficiency? We all divide the most common clinical feature, white dot spots, you already know, and we all divide the vitamin A deficiency clinical features according to the WHO classification. So this is the WHO classification. So first is the night blindness. Remember, like it is N for night blindness. Remember like that. And in the one form, you can see A and B. A, it is, see, the first involvement is always from the conjunctiva. Cornea is the next form. So remember, like conjunctival xerosis first, B for white dot spots, and in the second form, you can see the corneal xerosis. Corneal xerosis starts, and 3, you can see A and B. When the corneal ulceration is less than 1/3 of the corneal surface, it is A. And in B form, when the corneal ulceration is more than the 1/3 of the corneal surface, it is B form. And when you see the S, you remember like corneal scarring. And F for fundus involvement. Fundus, xerophthalmic fundus, you remember like F. So you remember like 1, 2, 3, N, S, F. In the 1, 2 forms, A and B, second is not only 1, and 3, A and B. In the 1A, starting with conjunctival xerosis, B for white dot spot, 2, start with corneal xerosis, 3, A and B, corneal ulceration less than 1/3, and B, corneal ulceration more than 1/3, N for night blindness, S for corneal scarring, and F for xerophthalmic fundus. So this is the WHO classification of vitamin A deficiency. So what are all the other factors affected in vitamin A deficiency or infertility? Vitamin A deficiency leads to infertility and even the metaplastic bones. Vitamin A is required for the keratinization of the epithelial tissue, particularly the skin, lungs, and GI tract, genitourinary tract. Vitamin A deficient patients may have even urinary calculi. Fetal anomalies are common in the vitamin A deficiency. So lab investigations to rule out the vitamin A deficiency. When you get a CBP done, you can see a leukopenia. That is the only thing which you can find, and vitamin A levels you can directly do it. So how do you treat this? How do you treat the vitamin A deficiency? So vitamin A deficiency is present. You should treat with oral vitamin A supplementation unless the child is having repeated vomitings or the child is having malabsorption syndromes or the child is in a SAM child. Then you go for IV or parenteral forms. So you can treat with oral vitamin A supplementations. Remember this form like less than 6 months, 6 months to 1 year, and more than 1 year. Less than 6 months, it is 50,000 international units, and 6 months to 1 year, 1 lakh international units, and more than 1 year, 2 lakh international units. That is the dosage. So how do you prevent this vitamin A deficiency? Our government has taken various programs like National Vitamin A Prophylaxis Program. And first, they have targeted the 1 to 5 years of child because that is the potential area when the visual cycle or vision starts. So 1 to 5 years. First, they started like every 6 months we go on giving the child 2 lakh international units. But later that has changed, like we'll target the 1 to 3 years of child, and during the immunization, which is the more convenient method. So during immunization, first during the measles time, when the child comes for taking the measles vaccine, that is during the 9th month, you can, so the dosage is for more than 6 months old child, the dosage is 1 lakh. So you give a 1 lakh international units of vitamin A, and the second dose during the DPT booster. These two should not miss. DPT booster, and the child is more than 1 year, so the dose increases to 1 lakh. During the DPT booster, you give the child 2 lakh. So at 6 months, 1 lakh, and at DPT booster, 2 lakh. So there are other forms like fortification of the food with vitamin A. So we have treated the child and there are prevention programs coming. Then how do you detect the hypervitaminosis. So hypervitaminosis is also very important for you. So if the child is taking more than 50,000 international units of vitamin A daily for several months, then you get hypervitaminosis. Or the adults are using some treatments or medications for acne, then there is a chance of getting hypervitaminosis. So what are the clinical features of hypervitaminosis? You get GI upset like malaise, nausea, vomitings, fatigue, and raised ICP symptoms like headache and diplopia, and bony pains, dermatitis you can see due to hyperkeratinization, and hepatomegaly or hypercalcemia, and fetal anomalies or hypoprothaminosis. If a pregnant woman is taking more than 7,500 micrograms daily at early fetal stages, you can get a poor fetal outcome. These are the features of hypervitaminosis A. So that is about the vitamin A. This WHO classification is important for you and it is a short note question. So next, fat soluble vitamin is vitamin D, very important form of vitamin in the fat soluble vitamins. So how the vitamin D is formed in our body? The external sources of vitamin D are very low, and how they are formed. So the skin contains the cholesterol, and in the cholesterol, 7-dehydrocholesterol is the form which is important, and when the sunlight falls on the skin, particularly the ultraviolet light radiations, they convert this 7-dehydrocholesterol in the skin to the cholecalciferol. That is the vitamin D3. What is this? This is not the active form. Vitamin D3 cholecalciferol is not the active form. That is just only a pro form of a hormone. So this is carried to the liver. So in the liver, by the help of the enzyme 25-hydroxylase, the hydroxylation occurs and it is converted to 25-hydroxy vitamin D3. So this again is transported to the kidney, and kidney it is again hydroxylation and it forms the 125-hydroxy vitamin D3, which is this is the hormone, or this is the active form, and in the kidney it occurs under the control of the parathyroid or tissue phosphate concentration. So this is the formation of the vitamin 125 hydroxy dihydroxy vitamin D3, which is the hormone. So why this vitamin D is important for us? We all know the rickets is the one of the manifestation of vitamin D which we see commonly in the pediatric age group. So how does this vitamin D3 get absorbed then? So the absorption is mainly from the small intestine, that is the duodenum part, and from the duodenum by the active transport it enters the enterocyte. From the enterocyte with the help of the chylomicrons, in the previous pathway we have seen it is in the liver. So small intestine, that is I'm discussing about the dietary sources. When it is taken from the dietary, small intestine, duodenum, active form enters the enterocyte. From the enterocyte chylomicrons, it is transported to the liver 25 hydroxylase enzyme converts it into 25 hydroxy vitamin D, and it is secreted from the liver along with alpha 2 globulin. So alpha 2 globulin attaches with the 25 hydroxy vitamin D. See the vitamin D, whichever enters the liver, it gets hydroxylated twice times in the liver, and this 25 hydroxy vitamin D3 is secreted to the kidney, and kidney 125 hydroxylase enzyme, so it forms the 125 dihydroxy vitamin D. So in gut it increases the calcium absorption. So it increases the calcium absorption from the gut, and it transports it to the bones, which helps in the calcium turnover. So 125 dihydroxy vitamin D is the hormone, and in intestine, this hormone induces a calcium transport system by CBP, that is calbindin, and kidney, it helps in the calcium reabsorption. As in the intestine also, it helps in the calcium reabsorption from the tubules in the kidney. So what are the sources of vitamin D now? So the sources are fish or liver oil. So breast milk is a poor source of vitamin D. Vitamin D and K are deficient or poor sources of breast milk. So if a mother is giving breast milk, you can supplement the mother with vitamin D. Fortified foods of vitamin D are available now, and milk contains very much low sources of vitamin D. So the recommended daily allowances of vitamin D are infants 5 micrograms, that is 200 international units per day. In children 400, double that of infant 400, and adult or pregnant forms 800 international units. So every day you have to expose the child 15 to 20 minutes to sunlight, and at least 20 centimeters square of skin should be exposed to get adequate forms of the vitamin D3. So what will happen in the deficiency? When there is inadequate mineralization of the bone, it leads to rickets. When the trabecular bone formation is affected, it leads to osteomalacia. And already in the adults, if the already formed bone volume is lost, it leads to osteoporosis. These are the deficient clinical features you see in a deficiency of vitamin D. And what is rickets? What are the clinical features? So in rickets, coming to the clinical features, you can see first if it is an infant or less than 18 months, wide open anterior fontanelle is the most prominent sign, and wide open anterior fontanelle, short stature. On general appearance, you can see a short stature or shunted growth, and you can see spine deformities. And in the picture you can see the pigeon chest, wide elbow joints, arch-shaped ribs, wide wrist joint, pelvic deformities, wide knee joints, bow legs, and wide ankle joints. So the clinical features are bow legs, wide open anterior fontanelle, bow legs also called as genu varum, knock knees, genu valgum, craniotapes, soft or ball-like skull, spine deformities and pelvic deformities, rachitic rosary, that is the costochondral swellings. Rachitic rosary are nothing but the costochondral swellings. Harrison's group, the muscles attached near the diaphragm, these form the Harrison's groove. Double malleoli, which occurs due to metaphyseal hyperplasia, and increase the risk for fractures, mostly the green stick fractures and the bone pains and bone tenderness. These are the clinical features of vitamin D deficiency. So coming to the X-ray, the first feature which you can see in the X-ray is the loss of normal zone of calcification adjacent to the metaphyseal part. So the zone of calcification is lost, which results in frayed appearance of the bones and widening of the growth plate. So if a child with vitamin D deficiency comes to you, when you should observe the AF and any abnormal skulls and the costochondral beadings or the Harrison sulcus, and at the wrist part you should palpate the wrist and see for the widened wrist present or not. And in X-ray you can see the fraying, and weight bearing of these areas lead to cupping appearance and also splaying of the metaphyses. cupping and splaying you can see at the metaphysis levels. So in the laboratory investigation, how could you detect this vitamin D deficiency? Is the deficiency of the, you can go directly with the hormone levels, but you should send both forms like 25 hydroxy vitamin D and 125 dihydroxy vitamin D3 also, because you should know where the process is getting disturbed, whether in the liver or the kidney. So if the levels are less than 10 microgram per ml, you can say it as a low levels, and you should see the calcium and phosphorus levels also. The calcium levels are low or normal, and phosphorus remains unchanged also. So the calcium, when the vitamin D deficiency is there, calcium deficiency also will be there, which in turn leads to secondary hyperparathyroidism. So the blood PTH levels are always elevated, and you should see the alkaline phosphate levels which are elevated in the vitamin D deficiency. These are the laboratory investigations. Go for an X-ray of the wrist and go for an X-ray of the knee joints also if needed. So this is the picture showing the rachitic rosary at the attachment. See the muscle attachment at the diaphragm area. So these are the 10 important clinical features in rickets: delayed closure of anterior fontanelle, frontal bossing, wide sutures, craniotapes, dental hypoplasia, rachitic rosary, Harrison sulcus, pectus carinatum, swelling in the wrist and ankle joints, bowing of legs, genu, varum, and knock-knees genu valgum. These are the clinical features which you should not miss. So how do you treat this vitamin D deficiency? You should give a single dose, that is 6 lakh international units. Go with a 6 lakhs at a single dose, or 60,000 per day for 10 days. 6 lakh at single dose or 60,000 international unit per day for 10 days, and after that you go on for a maintenance dose. If the maintenance dose is 400 international units, supplement with maintenance dose. And while treating the vitamin D deficiency, you should always treat the calcium also. 50 to 75 mg per kg per day is the dose. Treat calcium deficiency also. After 4 weeks of treating, take an X-ray, because it takes 4 weeks for the zone of ossification or zone of calcification to appear. Take an X-ray, see whether there is healing or not. If there is no healing, you give 2 mega doses. You can again repeat the dose. Take an X-ray after 4 weeks and again repeat the dose. 2 mega doses you can give. And still it is not healing. Then what you should think is the refractory rickets. I'm not going into the depths of refractory rickets now. So take it as refractory rickets. And how do you rule out the refractory rickets? If I'm telling the protocol for ruling out the refractory rickets, if there is refractory rickets, the first thing you have to do is a serum phosphate levels. So if the phosphate levels are high phosphate levels always rule out chronic kidney diseases. See whether there is any chronic kidney diseases and treat it. If so, that is one of the cause of refractory rickets. If the serum phosphate levels are low or normal, then go for a ABG. See the pH level in the ABG. If the pH levels are low, so the serum phosphate levels are low or normal and the pH level is also low, then it is the renal tubular acidosis. So treat the renal tubular acidosis, automatically your vitamin D will be treated. If the serum phosphate levels are also low and in the ABG taken from the blood, the pH is high. So the pH is normal. The pH is normal. Then go for a calcium and PTH levels. If there are normal PTH and normal calcium levels, then it is a hypophosphatemic rickets. If there are increased PTH levels and low calcium levels, it is vitamin D dependent rickets. This is how you should rule out the refractory rickets. So treat the refractory rickets also. And next is the vitamin K, vitamin K is one of the fat soluble vitamin which is important for you, and vitamin K function is in all, we all know that vitamin K is a procoagulant. It prevents bleeding. So three forms are there: K1, K2, K3. K1 phylloquinone in the plants, and K2 is the important form for us. K3 in the synthetic forms. K2 is menaquinone, which is produced in the human body. This is the only source in the human body present from the bacteria in the intestine. So the absorption of the vitamin K is mainly by the presence of bile and the pancreatic juices. It occurs from the small intestine. It is absorbed and it is attached to the chylomicrons. By the chylomicrons, it is released to the circulation through the lymph. So it mainly is present in the liver. 80% is present in the liver itself, and the other organs are the skin and the muscle. So it is a cofactor in one of the most important functioning of the vitamin K is it acts as a cofactor in post-translational carboxylation of glutamic acid from glutamate. This is the one of the most important function, and it helps in the formation of factors like 2, 7, 9, 10, and in the protein C and protein S formation also in the liver. All this help in the coagulation pathway. So how does this deficiency occurs is either we already discussed that bile juices and the pancreatic juices are needed. So malabsorption child or biliary obstruction, children having cystic fibrosis or short bowel syndromes, these are the etiologies for vitamin K deficiency. So if there is vitamin K deficiency, what happens? In the children, you can see bleeding tendencies, and in the neonates, HDN, hemorrhagic disease of newborn, which manifests as GI bleeds or petechiae purpura or nasal bleeds. So bleeding is the clinical feature which is seen. So what we do, it is now recommended that whenever a child is born, whenever a neonate is born, so you give him, if it is a preterm, 0.5 mg of vitamin K, you give IM injection in the anterolateral part of the thigh. If it is a term baby, 1 mg in IM of vitamin K in the anterolateral part of the thigh. That is the dosage you have to give it prophylactically, as it is deficient in the breast milk also. So if there is an HDN, then you give 1 mg on day 1, 2 and 3, and 1 mg daily weekly until the neonate is discharged. So if there is a already detected hemorrhagic disease of newborn, 1 mg 1 to 3 days, and weekly 1 mg you give still the baby is discharged from the NICU. So this is about the vitamin K deficiency. And vitamin E, this is a powerful antioxidant, and the main clinical features of the vitamin E deficiencies are the hemolytic anemia in children. The hemolytic anemia, the children will have 7 to 9 grams of deciliter in vitamin E deficiency. It provokes the neonatal jaundice and reticulocytosis also. The other features are spinocerebellar ataxia, loss of deep tendon reflexes, truncal and the limb ataxias, presence of ophthalmoplegia, ptosis, loss of vibration and position sense, and pigmented retinopathy. These are the clinical features of vitamin E deficiency. So how do you treat them? The oral vitamin E, 100 to 200 mg per kg per day. This is the treatment, and you advise them sources of vitamin E like green leafy vegetables, nuts, fish, and breast milk. Breast milk is a good source of vitamin E, and fruits. These are the sources. Usually vitamin E occurs when there is low placental transfer from the mother to the child, and when there are malabsorption syndromes in the children, and when the child is going on with the formula feed which has high polyunsaturated fatty acids which inhibit the vitamin E absorption. So stop all the family of foods, and breast milk is a very good source of vitamin E, and you start the vitamin E through the advise the mother to go on with the breast milk. So these are the fat soluble vitamins. Thank you. Please save your chart and you can leave the meeting.